Jane, someone's got their hand up. One of the practice managers.
Okay.
Oh, no, hand's gone down.
Okay, so it's 1 o'clock now, so perhaps we'll get started. Could you just indicate whether you can see my slide and whether you can hear me? That'd be really helpful. Yep, that's brilliant. Thank you very much. Okay, so hello everyone, and welcome to the final webinar in the series for this year's Prescribing Quality Scheme. So today we're going to focus on Target 5, which is all about falls prevention in the elderly, and that's particularly relating to medication. So my name's Jane Bennett, and I'm one of the ICB Medicines Optimization Pharmacists. And later we're going to hear from Dr. Dan Johnson, who's an elderly care consultant at the Royal Berkshire Foundation Trust. So before we start, just a bit of housekeeping, which I'm sure you're all very familiar with, but it has to be done. So please, can you ensure you switch your cameras off during the presentation and put your microphones on mute so that we can keep interruptions to a minimum. You are, of course, welcome to switch them on if you want to ask a question during the Q&A session at the end. So if you do have any questions, particularly those that are relating to the PQS in general and this particular target, please, if you could put them in the chat, then depending on what the questions are, they may be answered by a member of the MOT. Or for questions relating to specifically to falls and medications, hopefully Dan will be able to help answer those at the end. So I need to tell you that the webinar is being recorded and it will be uploaded to the PQS SharePoint page along with the slides. So hopefully you can all see the agenda. So I'm going to start off with a brief introduction to PQS in general and then move on to talk about this particular target, Target 5. And I'll talk a little bit about why we've chosen this target as well as the requirements. Then for the bulk of the webinar, Dan will talk about a geriatrician's approach to falls preventions. And then we've got 10 minutes for questions at the end. Okay, so to start off, I'm going to talk about the PQS in general. So the Prescribing Quality Scheme, or PQS, is an annual scheme which this year runs from April 25 to the 31st of March 26. And the overall aim of the scheme really is to improve the quality, safety and cost effectiveness of prescribing. And so, but obviously we're only asking you to review a small snapshot of the prescribing within your practice, but the hope is that you'll learn from this and you'll use this learning in the future to benefit many more patients. So a bit like a sort of quality improvement. The scheme is open to all GP practices in Bob, and although it is voluntary and practices can choose to participate, the majority have signed up this year. So in order for practices to see how they're progressing, a monthly dashboard will be circulated. So moving on to a few details about this year's scheme. So hopefully you already know this, but there are 5 targets and each are worth 20 points. And the practices will have already been informed about the monetary value of that scheme in April, which is different for each practice. So as I said, there's 5 targets. So the first one is overuse of short-acting beta agonists in children. The second one is formulary compliance of oral nutritional supplements. Number 3 is oversupply and repeat prescribing, process review. 4th one is DOAC optimization in patients with atrial fibrillation. And then lastly, the one we're going to talk about today is the falls prevention in the elderly. So whilst we would encourage practices to participate in all the targets, they can choose to do any of them and they will be then rewarded accordingly. There are, however, a couple of elements of the PQS which are compulsory for practices taking part. and I'd just like to really briefly mention those. One is the script switch requirements. So I really don't want to go into this now, but they are outlined in the participation agreement, and there is also a webinar which obviously you can watch. It's available on the on SharePoint. And then the other one is about our unwarranted variation in prescribing. So we, as a team, we regularly monitor practices for variations in their prescribing compared to other GP practices. We particularly focus on things like the prescribing of branded medications, on unlicensed specials, and unusually high-cost items. And although we totally understand that there is some need to prescribe these for individual patients, so you might have a patient that needs a particular brand, they're intolerant to some excipients, or maybe they need a particularly like an unlicensed formulation. We do understand that. If the prescribing of these items turns out to be what we'd call unwarranted, so there's no particular reason, and there doesn't appear to be a move to switch to alternative medications, this could possibly affect your PQS payment at the end of the year. But the practices will be informed of this and given plenty of opportunity to make the required changes. Okay, so moving on. So as I said, for each target, there has been a webinar. So we've had five webinars, including this one. And also there was one about the script switch requirements. And all the webinars are available on SharePoint. And I would encourage you to revisit them if you're unsure about any elements of the PQS. So I just briefly want to talk about the PQS resources, which are available to support you. So hopefully you all know where the page on SharePoint is, and the page includes details of the scheme, the participation agreement, the clinical system searches for EMIS and System 1, the data collection templates, and as I said, links to the webinars. So hopefully you will find all the information you need on there. But if you do find you've got any questions about any aspect of the PQS, please feel free to email the MOT mailbox, and you can see the address there. Or you can contact your link pharmacist. So each practice has a link pharmacist in the ICB who should be able to help you. So feel free to contact them as well. Okay, so I'm now going to move on to talk about Target 5, which, as I said, it's the falls prevention in patients aged over 65 on 10 or more repeat medications. So I wanted to choose a little bit to just mention a little bit about why we chose this target. So the Better Care Fund metrics show that in Bob in 2023 to 4, 6,778 people over the age of 65 had an emergency admission to hospital for a fall. So you can see from those figures there's obviously room for improvement. And also if we work to reduce medication-related falls, that does have the potential to improve quality, safety, and cost effectiveness of prescribing. So that ticks all the boxes that I mentioned earlier. Why did we choose the elderly? Well, sadly, falls do occur more often in the elderly. Research has shown that in people over 65, about 1/3 of them have at least one fall a year. And then this figure increases to around half in people over 80 years. So that's really why we've focused on people over 65. And obviously, they're more likely to be taking more medication. So I just wanted to say a little bit about the impact and the causes of falls. Now, Dan will be talking about this in a lot more detail, and I don't want to kind of steal his thunder or duplicate what he's saying, but I just wanted to talk a little bit about the impact of falls. So even just one fall can result in a person no longer able to live independently. They might manage with increased help from their family members, or they might become reliant on visits from professional carers. And alternatively, they might need to relocate to a residential home. Even if they can manage to stay in their own home, they might require their house to be redesigned or to have to resort to sleeping downstairs. but the likelihood is that they will lose the ability and confidence to undertake tasks that they had previously managed. So I'm sure you can appreciate that the impact of a person falling can be very far-reaching and can have a massive impact, not only on the person themselves and their family, but also on the health and social care system as a whole. So what about the causes of falls? So there are many causes of falls in the elderly, and actually often when a person falls, it's likely to be multifactorial. It's likely to be lots of reasons why that person's fallen. And just some of the things I'd thought of were that the elderly are often less mobile, and particularly if they've had a period of ill health, this can lead to muscle weakness, and then they get issues with their balance. Visual impairment, they may have cataracts or macular degeneration, or just a general deterioration in their eyesight. Dehydration, quite a lot of elderly people don't drink enough, and sometimes this may be a way of actually managing incontinence issues, but then that can lead to low blood pressure and sort of confusion, more likely to fall. You've got environmental hazards such as poor footwear. A lot of elderly people are staying at home and they wear slippers all the time. You may have trip hazards in the home, and even if they manage to get outside, you've got uneven pavements, and in the winter you might have icy conditions, etc. So, and then there's certain medical conditions can increase a person's risk of falling. So be conditions like Parkinson's or arthritis, dementia, hypotension, possibly due to overtreated hypertension from maybe years ago. They were on antihypertensives and they've never been reviewed. And also previous falls. If a person is now walking with a frame, it makes them much more unstable than they were before. So as you can see, there are lots of risk factors for falls, and even without considering the person's medication. But of course, there's polypharmacy, and we're all aware that many elderly people are prescribed a cocktail of medications in a prescribing cascade, and some medications will undoubtedly have a strong link with falls, and we call those FRIDs, falls risks increasing drugs. Okay, so that's just a little bit about the causes of falls. I now want to move on to talk about the data collection templates, which I'm sure you're very familiar with. But I'll run through them for this target. So when you have a look at the data collection template, and you'll see that there's 4 tabs on there. So the first one is called the background information tab. So this includes details of the requirement for meeting the target. And the practice must review all patients aged 65 and over on 10 or more repeat medications who have had a fall in the last 12 months. And then we want you to do is do an initial review of all the patients that come up on that search, and they should assess the patient's frailty, number of falls, and the medication which the patients are taking to see if there are medications which are associated with an increased risk of falls, i.e. whether there's any FRIDs. And where FRIDs are identified, the patient should be considered for an SMR. Also on the background tab, there's facts and figures to support the rationale for choosing the target, which I've kind of mentioned a little bit already. And then there's lots of useful resources to help you with this target, particularly information to help you identify the FRIDs, and also a recorded masterclass produced by the Health Innovation Network, which is called Medicines and the Risk of Falls in Older People. So I'd really encourage you to have a look at that. And then moving on to the instructions tab, this explains how to run the searches and download the reports, which I'm sure most of you are very familiar with now. It also shows you how to use the reports to identify the patients who should be considered for an SMR, and what information should be provided on the spreadsheet to allow the MOT panel to assess the evidence provided. So moving on to the third tab, this is called Details of Meds Prescribed tab. So this tab should be used to record the medications prescribed for all the patients that have been identified in the search. So that's your initial search that you do. And then you need to look at each medication and decide if it is classified as a FRID, and also calculate the ACB score. And then this information will help you decide which patients require an SMR, and not all will. But then moving on to the fourth slide, the fourth tab. So this is called the evidence sheet to return to MOT tab. So this tab should be used to collate all the information required for the evidence submission. So I'm sure you'll be glad to know that you can populate the first 6 columns with the data from the previous template, and you can also transfer information. Sorry, is there a problem with the?
No, don't worry. I think.
Does it sound okay?
We can hear you, Jane. Yes, go ahead.
Okay. I forgot where I was now. But if a patient isn't suitable for an SMR, so when you've looked on your first initial trawl and you find patients don't need an SMR, maybe they're not on any medications, you need to write this on the fourth tab and just justify why you're not doing an SMR and document it. And where a patient is deemed appropriate for an SMR, indicate the date that the SMR was done and give a summary of the interventions. So I'm really hoping that that has gone to some way explaining how to complete this target. So I'm now going to hand over to Dr. Dan Johnson, who is the elderly care consultant at Royal Berkshire Hospital Foundation Trust.
Cool. Thanks very much for inviting me along. Are you going to be controlling the slides there?
Yeah.
Okay,
I'm say yeah. So just shout when you want me to.
That'll be very, very prof-witty. We'll do next slide, please. So been asked to come along to have a little chat about falls from a sort of geriatrician's point of view. So there will be a bit more of a focus on medications in particular, but I'm just going to briefly cover some of the other things that we'd like to consider because as was mentioned just now, a lot of the causes of falls are generally multifactorial, so our interventions are multifactorial, and medication review certainly is an important part of that process, but it's not the whole of it. So I'm just going to touch on a few other important areas to mention before we go into a bit more depth on some of the favourites, as it were, that we like to meddle with when we see people in the clinic today. Yes, we can get next slide. So as was previously alluded to, falls is a very common issue with over half of people falling at least once a year when they get to age over 80, and it costs the NHS billions every year. For example, just the cost of fragility fractures of around 4.4 billion, of which roughly a quarter to half of that is related to neck femur fractures. And not only is the cost of that relevant, but also there is an associated increased risk of morbidity and mortality. And there's also significant implications, as noted, for health and social care with increased care needs, and so either that being more care at home, changes to the home setup with more equipment, moving into residential care, etc. So that is a major factor. And almost, this is sort of data from a couple of years ago, but around 250,000 presentations to ED every year happen at around 2022-23, of which a reasonable proportion of them are admitted to inpatient as a result of the injury sustained, the need for intervention, or the fact that as a result of that fall, even if it's not a physical bone break, other things have developed, which means that they can't immediately go home, for example, developing infection or additional social care needs, etc. So next slide. And as I said, so we can break down some of those consequences of falls are not just the injury, and the things we sort of think about are things like head injuries, particularly if people are on anticoagulation, but broken bones, with neck of femur being an important one. And if people can't immediately get up off the floor, there are other risks, that can be related to the surface that they've landed on, be it a sort of a hard floor in sort of, kitchen sort of area, or if it's that's a higher risk of causing muscle and skin breakdown than somewhere if they've landed if there's sort of a carpeted area, and also based on a person's body weight and how much muscle mass there is, and what sort of is overlying any bony injuries, the risk of muscle and pressure damage can be quite rapid. It's not been unheard of for people in the emergency department to have been on a stretcher for so long that they've developed pressure damage, which is why we try to get people onto beds if we're anticipating them being admitted or staying in the emergency department for a while. And these are things that we sort of start to consider from a physical injury, but also the fear of falling itself is a big issue. And as a result of it only takes one big fall to shake a person's confidence, even if they haven't necessarily had a major injury, and they start to be quite reluctant to get up or do anything because of that fear of falling, and that reduction in their independence, their reduction in mobility, reduction in activity, then feeds into loss of muscle mass, development of sarcopenia, and actually an increased risk of future falls because of that inactivity. And people start to try and cope with what they feel are sort of sensible ways of mobilizing around the house, but paradoxically increase the falls risk. They'll sort of start to furniture surf, and sort of, if they don't have any proper walking aids and there's a bit of a gap between where they are and sort of say the kitchen countertop where they want to get to, they'll sort of be leaning on one thing, trying to reach over to that kitchen counter surface before they start walking towards it. And because that center of gravity is suddenly in an awkward or unnatural position, that paradoxically makes them more at risk of falling again, because they start to overthink it. Walking is a thing that everyone's done pretty much since they were toddlers. And for the vast majority of life, you've not given any thought to it. The moment you start thinking about how are you walking, what's the actual mechanism of left foot, right foot, left foot, right foot, it does start to become quite an abnormal thing the more you think about it. And this is what sort of feeds into both that fear of falling, but also overthinking how you are walking to increase the risk of future falls. And then there were other consequences as well. So for example, infection. If you're lying on the floor horizontally for a prolonged period of time, the risk of microaspiration goes up, so the chance of developing a chest infection is increased. But we also sort of need to bear in mind sometimes infections can be a cause of falls if someone is becoming unwell, if they've got a bit of frailty, that physiological reserve is lost, or they're getting a bit confused and a bit delirious. That can be a cause of fall as well as a consequence. So it's again important things that we all like to consider when a person has been falling. Okay, next slide, please. And a lot of people at risk, and the nice recommendations are that we consider who could potentially be at risk to try and intervene as early as possible before more significant falls occur. From a hospital point of view, it's everyone aged over 65 who's been admitted to as an acute inpatient, and that is extended to anyone who's a bit younger, from 50 to 64, if they have a concurrent issue which make them increased risk of falling, such as previous stroke, impaired vision, so Parkinson's disease, etc. But we should all, no matter what the context we are in primary care or secondary care, be routinely asking older patients whether or not they have suffered a fall in the last year. And based on those responses, we should be considering onward action. So that might be a referral on to some of the local fall services, and they will differ all throughout the BOB. But, for example, here in the Reading area, we've got our MDT-based falls clinic here on site, but also there's lots, because we sit between lots of the different unitary authorities, there's lots of different community-based falls services which can also be referred to by our GPs locally. The advice is to avoid using risk prediction tools for people who may be at risk of falling, because the evidence is that they're not that reliable, and so they're not actually that helpful at identifying who is more or less at risk of falling. The assumption is that everyone over 65 should be regarded at risk, and hence we should start doing something about it to try and reduce that risk. Next slide. So one of the things that we always want to think about when we're assessing the falls is why it is that they've actually fallen. We hate that word, those words, mechanical fall, in elderly care. Quite often when we see that, what people are alluding to are that it's been a slip or a trip, which is absolutely fine. Say it's a slip or a trip, because then that might start leading us down the route of why are they slipping and tripping? Is there an issue related to their footwear? Is there an issue related to peripheral neuropathy? And that's why they're having these episodes. Or is it in other things? Is it environmental factors around the house? And so that form of a slip or a trip is very different to someone who is falling every time they try to stand up because they're feeling dizzy and lightheaded. That pushes us down a completely different avenue of what we might be considering as the highest risk. And what we still need to do, both in our falls assessment, but also as part of the medication review, is acknowledge that no matter what we do, although we like to think we can reduce the risk of falling, it can't completely eliminate that risk, and people will probably fall again at some point. So what can we do to reduce the risk of harm if they were to fall? And that feeds in again to not only the falls clinic review, but the medication reviews that we do as well. Okay, next slide, please. Some of the important medical things that we always like to keep in mind: if there's anything to suggest a person has been losing consciousness, then we start to think about orthostatic hypotension, cardiogenic syncope, be that due to an underlying arrhythmia or a structural abnormality such as aortic stenosis, or seizure activity. And I'm sure you're aware the way to delineate between the two is how rapidly things return to normal, whether or not there's immediate recovery or a post-ictal period. Is there another underlying medical issue such as a movement disorder like Parkinsonism, or is there developing lack of hazard awareness due to a mild cognitive impairment or a dementia? These are all sort of things that are really important to think about, because it will feed into our wider falls intervention package, but again, it will bear relevance to what we do when we do our medication review. Okay, next slide. A couple more important considers. So if we find some lateralizing neurology, we quite often in the falls clinic find that people have had missed strokes, particularly non-dominant hemisphere strokes, because they're the ones where people tend to be less aware that they have had them because of neglect. Medications, then that can be both prescribed medications, but also any form of other drugs. So alcohol, for example. I have had a referral to the falls clinic before for someone who was falling over repeatedly, and they arrived to clinic drunk, which sort of answered the question quite rapidly as to what the issue was. But yeah, so think about those other recreational drugs that they may be on, even in advancing ages. I have people still taking cannabis at quite older age and are a bit sort of spaced out as a result and tripping up. Continence, and then those home hazards as well, which we touched on. These are, again, all these things that feed into our falls review, but again, there are lots of relevance to medication as well. So next slide, please. If we find an underlying medical cause, we look at what we can do to try and treat it. So initiation of treatment for Parkinson's disease, for example. If we're finding arrhythmias, liaising with our cardiology colleagues for sort of consideration of pacemakers, etc., like that. But then a big part of it is the medication review, and we tend to use in geriatrician circles this thing called the stop-start criteria, which I'll talk about in a bit more detail in a moment. But then again, therapy reviews, ideally at home, to see what those home hazards are like, eyesight assessments, and it's that the causes of falls are multifactorial, so our interventions are multimodality as well. So moving on there, please. As when we think about medications, we need to acknowledge that there are a lot of physiological changes that occur with aging just naturally. And this in turn has an effect on both the efficacy and the side effect profile of the medications we're giving. So for example, gastric pH tends to be a bit higher as we get older. So drugs that are enteric coated and need to be dissolved in order to facilitate absorption are less effective. Fat soluble medications have their half-life potentiated, because as we get older, irrespective of your weight, the proportion that is muscle, bone, blood, and body fat changes to be a higher proportion of body fat. And there's other things such as changes in renin-aldosterone access and circulating antidiuretic hormones. These are all natural changes which we see sort of all the time. It's one of the reasons why people, when they're older, tend to need to go to the toilet more frequently at night, because the kidneys lose their concentrating ability and the bladder fills up more regularly. And that in turn has effect on the medications that we sometimes use. Next slide, please. So the stop-start criteria, if you're not aware of it, it's the screening tool for older persons' prescriptions, which is the stop, and the screening tool to alert to right treatment, which is the start. So it's essentially looking at medications which we might want to try and get rid of because they're not appropriate, as well as things which we should consider starting in particular clinical circumstances. And it's a really nice sort of break. You can find it online. It's broken down by body system, so cardiovascular, gastrointestinal, etc. And it comes with a lot of the stop and then followed by the start. So it's a really good thing to have a look through. I've pulled out some of the really important ones related to falls prevention here today. So particular things that we like to focus on are over treatment of hypertension. We know the benefits of blood pressure control are slightly reduced as we get older when it comes to primary prevention, because the chances are people may not be alive long enough to actually feel the benefit. But if we start to overtreat and we cause that postural drop and hence are causing people to fall over, that swings the pendulum away to towards tolerating a higher blood pressure if it reduces the risk of them falling over. To diagnose a postural drop, what we need is a lying and standing blood pressure. So ideally lying for 5 minutes, blood pressure check, stand them up, and then keep them standing with repeat blood pressure checks at 1 minute, 3 minutes, and ideally 5 minutes. And we're looking for a systolic drop of 20 or a diastolic drop of 10. And if we find that, that is diagnostic of a postural drop. And one of the first steps we should be doing to deal with that is to look at any blood pressure lowering medications that we can try and reduce or get rid of. I'll just make an aside note that sitting and standing blood pressure recordings are non-diagnostic for the purposes of identifying orthostatic hypertension. It does need to be that lying and standing check. Amitriptyline is a really nasty drug, and we try to avoid giving that to anyone aged over 65 where at all possible. It can really badly cause worsening of confusion. It increases your falls risk, and we inevitably, if it's there and you come into hospital and you're seen by a geriatrician, we will start the process of either weaning it or just stopping it outright. Proton pump inhibitors are another one we like to look at, not because of the concept of hyponatremia, which is what all the residents sort of try. That's their main reason for wanting to stop it here in the hospital, because it gets drummed into them at med school. But actually, from our point of view, it's because it can cause osteoporosis when taken in the long term, and the bigger, more worrisome side effect is it can cause both hypomagnesemia and quite severe hypocalcemia. And I'd say we probably see around one person every month at least coming into the acute medical unit with a calcium of 1.5 and all the associated symptoms of paresthesia, cramps, etc. And it's purely been driven by PPI use, and that can occur even if you've been established on treatment for a while. So what we say is we should only continue with the PPI cover if there's a concrete secondary reason to be on it. So that's Barrett's esophagus, hiatus hernia, or concurrent aspirin use, or something else that's going to irritate the stomach. In the absence of them, we do try and get rid of the PPIs if we can, because of that bone health point of view when it comes to falls. Next slide, please. So zopiclone and benzodiazepines, these are really nasty when it comes to falling over. People get addicted with them quite quickly, and when I try and address it in clinic, I will often be told, "Oh, but I need it, doctor, to sleep." And what I sort of tend to tell people is that actually the evidence is that you're not necessarily asleep when you're on these medications so much as you are unconscious. And there have been studies actually in that in a lot of people when they're on these benzos and Z drugs, if you put an EEG on them when they're unconscious, the brain is not entering the deep brain waves we see during true sleep, and that's what's needed to help leave us waking up feeling refreshed. But they are, particularly benzodiazepines, they are fat soluble, and their half-life is massively potentiated as a result, for the reasons I mentioned earlier. And so people remain quite lethargic, quite drowsy, quite sleepy throughout the whole day, and that in turn significantly increases their falls risk because their reflexes, their ability to maintain balance and homeostasis when mobilizing is diminished as a result of the side effects. There are some indications where actually, though, benzos can be of benefit for falls, and that's particularly related to people with REM sleep disorder in Lewy body disease like Parkinson's, because in that REM sleep disorder, they can have those very vivid dreams. They start trying to act them out, and we've had people falling in the middle of the night because they've believed that whatever it is they're dreaming is happening, and they're getting up, they're wandering around, they're trying to fight imaginary things. And so there's a trade-off to be had of, we can give the clonazepam to try and help with the REM sleep. There will be an increased risk of falling during the day because of its sedating properties. But again, it's a thing we sometimes consider when that REM sleep disorder is quite significant. Prochlorperazine we see quite a lot given out for people who are dizzy. There's a lot of evidence to suggest that the description patients give of in what way they're dizzy doesn't necessarily correlate that well with the underlying reason. People can use similar methods of describing dizziness, both for the dizziness associated with a postural drop, to the dizziness with a posterior stroke, to the dizziness of BPPV, and labyrinthitis, etc. So we do try to get rid of that procorpterism wherever possible, because it can induce a Parkinsonian-like state, which would in turn increase their falls risk. Dizziness is really challenging. I was at a stroke seminar many years ago when I was a registrar, and someone presented a whole series of patients who were dizzy and asked all the stroke consultants from across the region to put their hands up as to who thought it was a posterior stroke and who thought it was something else. There was no correlation between any of the stroke physicians as to who thought it was a stroke and who thought it was something different. And then everyone was horrified to be told, actually, they all turned out to be strokes. So dizziness can be really hard, but we do keep an eye on that prochlorperazine when it's crept in, because sometimes people continue to take it and actually it might not be giving them a huge amount of benefit. Thiazide-like diuretics, particularly for hypertension, we try to get rid of. We know the risk of hyponatremia doubles for every 10 years of increased age, but also the way it lowers your blood pressure by helping to remove circulating volume. That increased urinary frequency by needing to wee presents itself as a falls risk, because people sometimes are caught short. They need to be getting up a lot more frequently to get to the toilet, and if they have any other issues related to sort of a weakened pelvic floor or anything like that, it's not a nice thing to have incontinence, so people tend to rush to get there and hence can increase their falls. Metoclopramide is an antiemetic, again can induce Parkinsonism, so we prefer maybe a bit of domperidone if we're after a prokinetic. All of the antiemetics have a degree of side effects, but it's just to be aware that metoclopramide can induce Parkinsonism, so particularly when there's any concern about Lewy body disease in the background, we should try to avoid that. Next slide there, please. Tamsulosin, we know the way it acts on the alpha receptors to relax the smooth muscle around the bladder neck to help you wee. Those same alpha receptors are found in the smooth muscle, and hence it can of blood vessels, so it can induce a postural drop. But we quite often see people who have a long-term catheter in with a plan from urology for it to be never removed, who are still on the tamsulosin. The tamsulosin won't help with the catheter changes, because you're not at risk of retention anymore by virtue of having the long-term catheter, you don't tend to need to keep the tamsulosin on, so we can stop it in that situation. And likewise, we sometimes see tamsulosin, but also being used with tolterodine, mirabegra, and oxybutynin. I acknowledge there are certain instances when the urologists do like to do this, but outside of that, those small select group of patients, we find that we're sort of giving medications to both help them to wee, but also stop them from weeing. And the tolterodine and oxybutynin, for example, have a significant cholinergic burden with the increased sort of confusion and falls that they induce. So just be aware of that combination to try and help reduce. So I see there's pop up. Sorry. Yeah, so for postural drop, sorry, it's a drop of 20 millimeters in systolic or a 10 millimeter diastolic drop, and either on, if you find either of those, that's fine, and that is the diagnosis of a postural drop. And going back to the medications, antidepressants were a clear history of depression. That's the thing we commonly find. So quite often they get stopped after immediate bereavement, and we find sometimes that actually over time they say, I've been fine for a long period of time, so you can start to try and wean them down and ideally get rid of them. And particularly we like to avoid the tricyclics when there's any concern over underlying cognitive issues, because that may worsen the cognitive issues and hence increase their risk of falls from the impaired hazard awareness. Antihistamine point of view, there are some which are more sedating, which again can make you a bit more dulled in your reflexes and increase falls risk. So chlorphenamine, promethazine example. So for hay fever, where we need to be on it for a prolonged period of time, cetirizine is slightly kinder from that and would probably be our preferred option. Next slide there, please. Opiates, again, can be sedating, can worsen confusion. Everyone reacts differently to them, but we do need to acknowledge that they are often required if there's significant underlying pain, because if you've got a lot of pain and you've got quite an antalgic gait as a result, that can make you at risk of falling. So there's that trade-off to be had between eliminating pain as best we can to allow a person to walk as freely and confidently as possible, whilst avoiding the potential side effects and falls risk that might induce. Diuretics, so we always need to make sure that there is a good indication to be on them. So we were sort of avoiding trying to treat the leg swelling. That might be a side effect of a calcium channel blocker. If there's no elevated BNP and sort of and there's nothing on the to suggest that there's fluid on the chest, if it's just ankle swelling, they tend to say don't give it, because any improvement of quality of life by slight reduction in that ankle or calf swelling may well be offset by the falls risk of having to get up repeatedly to get to the toilet, and also the risk of dehydration in the hotter weather, as has been the theme of this week on call. And if I'm just from a nutrition point of view, we like to have a check on the B12 and the folate, particularly when there's any risk of developing peripheral neuropathy, which in turn will increase falls risk by impaired proprioception and an impaired ability to know where your feet are. So we just like to make sure that if they are low, we top them up properly. We tend to just go for IM hydroxycobalamin as a loading rather than trying the oral cyanocobalamin, because statistically, the highest cause of B12 deficiency in the developed world tends to be some form of pernicious anemia. It doesn't necessarily have to be an absolute, but it tends to be higher than dietary. But also, even if it is dietary, that is often because people are not necessarily taking good care of themselves. So relying on a once daily tablet might not be as effective as getting in with the loading doses and then relying on 3 monthly top-ups. The current recommendations as well are that even if you're normal B12, but at the low end of normal, the current suggestions are that you still reload and top back up again, particularly if there's any need to replace the folate, because if you're low normal and you're folate deficient, starting the folate can then induce a true deficiency in B12 and the complications that can induce. So just be aware of making sure the B12 is on the higher side. Next slide, please. So dementia, there is a trade-off to be had, because sometimes as people's dementia progresses and they may be suffering with behavioural challenges, particularly BPSD, we may need to give some form of more sedating medications for not only their safety, but also the safety of others, particularly caregivers or other residents if they're in residential or nursing care, for example. However, that in turn may increase their falls risk because they can be quite sedating. If we are looking for longer term things, we prefer something more like risperidone to haloperidol or benzodiazepines where possible, because it has a slightly kinder cardiovascular risk side effect profile and a slightly kinder side effect profile when it comes to falling. There is quite good evidence, though, that particularly in institutionalized care with people in dementia, if you give them regular paracetamol at its maximum dose based on their weight, etc. So, a gram 4 times a day. There's very good evidence that actually you can start to reduce their antipsychotic medications, because if they are struggling to interpret pain stimuli, they might be lashing out and getting aggressive, and that gets interpreted incorrectly. Take away those niggles by giving regular paracetamol. Behavior improves quite significantly, and you can often withdraw or reduce the more toxic medications that might be being used for sedation. Next slide there, please. This is probably better and better a lot to use. So the anticholinergic burden of drugs can vary, and we like to keep the score as sort of lower than 4 if at all possible, particularly in people with dementia. Ideally, avoid all of these drugs if at all possible. Next slide, please. So other interventions, just to touch briefly that we know work. Otago Strength and Balance is a quite intensive physiotherapy-led progressive exercise program, but it is known to reduce falls by 35 to 40%. I think I've got an example of the page of that on the next slide. So it's a pictorially guided thing where people are given exercises which start very simple, things like sit to stand. So you're working on your core stability, your hamstrings, your quads, your glutes, and it gradually progresses with an individualized program as your therapist is leading you forward to sort of heel-toe walking in figures of 8. It does get quite hard quite quickly, and then you can make the exercises more challenging by adding in weights, etc. It's really effective. Unfortunately, nothing like that is really available in the local area because it is quite intensive when it comes to the input from physiotherapists. When I say the area, this is in talking about my area here in Reading. It may be elsewhere in the BOB something like this is available, but this is one of the most effective interventions that has been tested around the world. Next slide, please. But as noted, we can't always stop people from falling over, so we still need to have a think about bone health and doing what we can to reduce the risk of fractures in future. If someone has suffered a fracture following a fall from standing height, we regard it as a fragility, and so we should start secondary bone protection medications and assume they have the osteoporosis. If they are under 75 and they've had a fracture, then you can use the FRAX tool to estimate what their risk of fracture in future is going to be. I've had a play around with this tool. I am yet to work out a demographic which leads to automatically having treatment. It always comes out with do a DEXA. I've put in the skinniest or the most overweight, smoking, steroid dependent alcoholic possible, and it still just goes, yeah, do a DEXA. But these are things to consider to reduce the risk of future fracture, particularly an atrial femur fracture. And bloods which are important to go hand in hand with that are those bone health things, but also if it's been a low impact trauma fracture and they're young, start to think about something a bit more unpleasant. So checking for PSA, for prostate cancer, potential for bony spread, myeloma, etc. And be aware there's a second spike of incidence in celiac and malabsorption in the 70 to 80 demographic. Next slide, please. So the bone health, we want a vitamin D and calcium combination, so AdCal or EvaCal, for example, with a secondary prevention medication such as alendronic acid. If you are strongly suspicious that someone cannot tolerate or won't tolerate alendronic acid because they've had a history of terrible reflux, hiatus hernia, Barrett's esophagus, etc., you can now move straight to a second line therapy. So you should be able to refer to your local hospital to their metabolic bone service for consideration of either IV zilendronate or denosumab. Zilendronate is currently the go-to bone hardening treatment following a neck of femur fracture, and that gets initiated in hospital. Vitamin D with calcium by itself, without any of those secondary prevention medications, isn't necessarily that helpful if they've got a good balanced diet with adequate calcium in from milk and cheese. And it's quite a chalky, chewy tablet. So you don't necessarily need to give AdCal by itself if they're not on these secondary medications. So maintenance vitamin D would be sufficient in that situation and is a bit better tolerated. Next slide there, please. A couple of things that we know doesn't work very well. So brisk walking, the evidence is that perhaps it may increase falls frequency. Untargeted group exercise therapy, which unfortunately does include some of our local Steady Steps programs. There's one area which does just sitting down exercises, which is not beneficial at all. Hip protectors, again, no evidence that they work. And although we know that correction of vision, particularly avoiding bifocals and varifocals, can be of benefit, because if you've got peripheral neuropathy and you look down through those magnifying glass components at the bottom of the glasses, it distorts depth perception and upsets the disequilibrium in your brain and makes you more likely to fall down. Correcting vision by itself doesn't seem to do much, but as part of all these other interventions can well be of benefit. Next slide there, please. And I've just covered that before having the slide up. Slide after that there, please. So yeah, that's a very quick rattle through. The bigger version of this talk goes on for much longer, so I've cut it down to fit into time and have questions. But it's just to say, yeah, falls are incredibly common. They're incredibly important, and a fall and the fear of falling and the reduction in mobility that can follow is often the single biggest thing that can reduce quality of life in the older age. The causes of falls are multifactorial, so our interventions are as well. And although we like to give consideration to underlying disease processes and things like that, medications are a very big part of what we do in the falls clinic and what we look at. And these are just some of the common things that we like to intervene with. And that stop-start criteria is not just useful for falls, it's useful for all patients who are older, and it's a really good useful read. If you're doing medications review, I'd encourage you to have a look at that. And yeah, on that, we've got 10 minutes to go, so I'll stop talking.
Thanks, Dan. That was really interesting. So, are there any questions in the chat?
So there's a couple. So there's a kind of question about long-term prednisolone for PMR. So it's a good question. My because when I've tried this looking at FRAX and I've put in that someone's been on steroids the whole time, it doesn't particularly come up with anything to suggest that you need to do the secondary prevention. I know there is a move to do the sort of the AdCal component, but not everyone who is on long-term steroids is also on the alendronic acid. So I would tend to lean towards that fraction if you're concerned looking at the DEXA, but at the same time, I will admit my rheumatology colleagues might be better placed to answer, are there particular situations where they empirically put people onto the secondary bone protection things as well. And then is the Otago strength and balance program with bucks? I don't know is the answer, I'm afraid. I'm just aware of what's available in the Reading area. I don't know, unfortunately. It's a thing which I would love to have because it is really, really effective, but it is very labor intensive because it's personalized one-to-one therapy time. And we know that one of the reasons why it works is because you have that one-on-one engagement with the physiotherapist, it improves compliance and motivation, as well as the nature of the exercises that are done. So there's a question that says, how do we assess degree of frailty? I'm not sure in what way you referring to that. Sorry, Paul. I mean, if you're writing an answer to further clarify, from a geriatrician point of view, we're not massively fans of frailty scores because our experience on that when they've been rolled out in areas where perhaps people aren't geriatricians and are as used to deal with frailty, for example, they can get misinterpreted and sort of incorrect scores being aligned. And I think what I've always sort of said to some of my backstory. My wife is one of the ICU nurses, and whenever the trainees are rotating through and they might be chatting to her, it used to come up when I was a medical registrar. They said, "Oh no, he's one of the med regs," and they'd say, "Oh, what specialty does he do?" And she'd say, "Oh, he's an elderly care registrar," and they go, "Huh, that must mean he's really nice," which. No, I'm not. But also, it's there's more to being a geriatrician than an infinite capacity of niceness. And what I sort of remember is that Jerry Reggers and Jerry trainees, we spend 5 years training to be specialists in old age medicine, and that ability to recognize what makes someone frail versus what makes someone have an end stage condition like end stage COPD on LPOT, on long-term oxygen, for example, might not be frail in the same way that one of my patients who has multiple things wrong with them, none of them particularly end stage, but as a result is frail. So it is quite a challenging thing to formally score identify. In primary care, I know that you can rely on things like the electronic frailty index can be useful at identifying people who are more likely to have a frailty syndrome. The most commonly used tool is that Rockford Frailty Score, which gives you a little description of a person and how their medical conditions and frailties impacting on their independence. That is sort of the tool that is most widely used around the country. But I will admit, there's in elderly care there is a pocket of us who secretly loathe it. We're not big fans of it because it boils what is quite a complicated and challenging syndrome and concept down into a numerical scale, which is always going to be at risk of perhaps either under or overestimating frailty. But that Rockford Clinical Frailty Score is probably the tool best used in primary care. There's been a question about giving leaflets for Otago. So during the pandemic, when I was limited to not anything no face-to-face, so doing video calls with patients in the Falls Clinic and then quite limited face-to-face with no physiotherapy cover, I had to resort to that to a degree. I would argue that it's not going to cause them harm having these exercises and showing them, particularly the very first few ones, which are the sort of the sit to stand, calf raises, squats, and things like that. But the evidence behind relying on just giving them to someone and leaving them to it is not as good. It doesn't exist because the way the evidence came from was having it personalized and progressed over time. The difficulty gets sort of ratcheted up week on week because, heel toe walking in a figure of 8, that's actually quite a challenging thing to do. So we wouldn't be asking someone to do that straight away if they're struggling to do their sit to stand. So we know that engagement and the sort of the direction is what really makes Otago work. what we did do, and I will do a plug because hopefully we'll be doing a bit more of this soon. We did a study last year called DARFIBS, which is it was called Dance to Reduce Falls and Improve Balance and Strength, with a colleague at Reading University who used to be a professional dancer, and we had people randomised to otago, paired tango dancing, or unpaired tango dancing. It was underpowered because this was being done just coming out of the pandemic and people were very reluctant to face-to-face contact with any of us. But the evidence we got in the unpaired tango, which has a lot of sudden changes of direction in it, was a massive increase and sustained increase in muscle mass, and actually a reduced falls risk. It's underpowered to get true significance, but we're hoping to do that in more detail. So if you're in the Reading area, we will be advertising this a bit more readily, hopefully in the next year or so. From a B12 injection, once you've loaded up, I would suggest maintaining maintenance. That's one injection every 3 months, because there's a reasonable probability that whatever caused their deficiency ought to be at the low end of normal may well recur. So I would continue maintenance at that 3-monthly dosing. I always say everywhere has their own different criteria for falls clinic. I'm quite open here at Reading. My approach is if you've had a fall within the last year, I would love to hear from you, because there are certain situations where I say actually we can't add anything more because we model ourselves on a rapid access. We can see people within 4 weeks. Normally you get seen by a geriatrician, we get a proper lying and standing blood pressure gun, you get seen by a physiotherapy, you get seen by OTO therapy in a sort of 2-hour mega MDT round robin clinic. So if I've been referred someone who's just had, earlier in the year, a fall, a neck and femur fracture, a stay in hospital, then a stay in the community hospital, and they're still below, I might not see them because we might not be able to offer much more because they've had a huge amount of the input we're going to offer them. But anyone else, if they have fallen, by and large, I'm quite happy to see, because yes, we pick up a lot of people where it was just a slip or a trip and nothing more to do. We normally can find something we can do to intervene, and every now and again we pick up a big thing, and we've had around 3 TAVIs performed to the non-bypass way of replacing a critically stenotic aortic valve. We've picked up quite a few missed strokes because they weren't aware that they had neglect on their left-hand side, for example. So most places by and large are just happy. We'd much rather hear from you so we can intervene, or say no, that's not for us, than for someone to go under the radar. From a preferred antihypertensive point of view, I mean, if you go off this sort of obviously nice guidelines where it's normally for the older people, we should be starting with either calcium channel blocker or a thiazide-like diuretic. Of the two, we would go for the calcium channel blocker, and then if we had to add in something else, we would do either an ACE inhibitor or an ARB. Obviously, if there's another underlying medical condition which might make them the preferable option, be a bit of chronic kidney disease or diabetes, then that from a prognostic purpose would sort of go in higher up our list. And then so evidence. So there's no particular evidence comparing one tool to the other. They've all they're all quite similar. So another one is Beer's criteria, which was created by the American Gerontology Association. They are very, very similar, but a lot of it is more that it's just been tailored to match the medications that are more commonly administered in the UK, and the underlying reasons for the breakdown of doing or not doing something is based on the sort of the UK or European guidelines as opposed to the American guidelines. But I'm not aware of evidence comparing different tools to say one superior or over the other. I think I've picked up all the questions there that have been.
It's quite good timing at 2 minutes to 2. So I suppose it just remains for me to say thank you ever so much, Dan, for coming along and giving us a really interesting talk. I think it's given us lots to think about, and I hope it will really support the pharmacists doing their PQS target. And yeah, thank you very much, and thank you to everybody who's attended. Really appreciate that, and good luck with the PQS.
Cool. Thanks very much for having me.
Thank you. Bye bye.
Bye bye.